Okay, so I'm really happy to welcome everyone back here in our Cairo University Plastic Surgery Department scientific meeting. It also gives me great pleasure to have tonight Dr. Robert Mann, who I've known recently, but of course I had a very long history with the oral cleft surgery, over 35 years. It's really a pleasure to have you tonight with us, sir. Our talk tonight will be discussing palatal fistula management and repair. I hope you all have a good time, and please place your questions in the chat box. If you need to address them personally, just raise a hand. Dr. Robertman?
Well, thank you very much, Matt and Dalat, for asking me to come today. It's an honor. I always enjoy coming back and speaking with my friends in Egypt. So thank you very much for that. I'm going to share the screen and start my talk here.
Okay.
So what I'm going to talk about is palatal fistulas, but I'm really going to talk about what we can learn from our complications here. So today I'm going to have an introduction. I'm going to talk about what our goals are for cleft surgery, talk about complications and what they taught me, and what do I do now, and then how you can do what I do and make it work for you as well, and how you can make it better going forward.
بس هي ما عملتش كده، مش تكون ممكن حاجات اللي لخبطت.
Sorry, just a second.
Bullet, that one operation that will give us universal good results without complications. And we've all had the opportunity to see many visiting professors who come and they present their latest repair with such enthusiasm that we leave the lecture surely feeling we've finally found that operation that we've all been waiting for. But I'm not going to do that. I will tell you my career's journey and describe to you what I think the things I changed in my journey that helped me design multiple procedures which have improved my personal results. But more importantly, I hope to clearly outline some of the limitations of my work. And I'm going to do something that I doubt you've ever heard before in a cleft lecture. I'm going to give you a guarantee. Because today I hope to equip you with a new philosophy that will expand your mind and have you look at clefts in a way that you've never looked at them before. Such that you and you and you, here I'm doing that virtually, will be the next person to discover the new tissue replacement flap in addition to the buccal flap. So I'm often referred to as the buckle guy. And I've even been given a belt buckle. It says Bob on it when I was down at the University of Texas Southwestern doing some teaching. So down there they call me they call me Buckle Bob. So at meetings I'm asked to show different ways to use the buccal flap, and the buccal flap is a wonderful tool. And more importantly than the ways that I've used it in multiple ways in my practice, I was able to analyze what the buccal flap does in the reconstruction. And that has really given me a better understanding of the anatomic deficiencies that must be addressed in the reconstruction in the more complicated clefts. So I'm plan on giving you these tools for success through a candid view of looking at why we are failing. But you're not going to make a change unless we critically look at our failures. And I certainly did that within my own practice. It forced me to open my eyes and look at a new way to treat clefts. So I started my journey looking at the clinic like we all did, and we see the kids that look like this. So the lip posture looks like they're pouting all the time. It's cute when they're a baby, but not when they're older. And their teeth are malaligned and they have mid-face protrusion and their palates are scarred and maybe they don't speak well. But I started out like we all did in the clinics, seeing these kids. But I thought when I finished, I'm going to do better. And I thought, I'm going to get better results. But shortly I recognized that my results are exactly the same as the previous generation. So here's a gentleman I went to church with. He just passed away. Ed had mid-face protrusion and mouth breather, so he lost all his teeth. He had poor speech. Or Dorothy. Or Larry with a pharyngeal flap, and he's losing all his teeth. And he brought me his son, and I fixed him up, and he was a cute little kid. Like you say, you can see his face as a child looks the same, and as a young adult, he's clearly going to have significant orthognathic surgery. And here's a child who came to our clinic this year from another fine institution. You can see the problems she's going to have. And these are the clefts that we still see today. And these were the things that I saw that really got me thinking about the goals. So what are the goals? Well, I think globally the goal should be normal speech and normal face. And I think everyone agrees that these are good goals, but are they achievable? Well, I think speech, everybody focuses on that, and I certainly did too. I really did. I thought that if I could get these kids to speak right, even if their face wasn't perfect, at least they had a chance in society. If you can't speak, you have no chance. But as I've come to determine, the face is equally important in many things, but some people still feel that the VO 3s and 4s are so genetically malformed that their mid-face protrusion is really a foregone conclusion. But I have found after the many years of following my kids that this is not true. And we're doing cephalometric and MRI studies, and I think as those studies come out, we're finally going to put that to rest. And one of the other problems we have is at our meetings, this is what you see. You're going to see kids that we show you great results, but we're looking at children. So I can show you this result, and I can show you this result, and I can show you this result, even in a wide VO 3. But I'm showing you children. And if we only see these results, and I can't tell you how many meetings I go to where I don't see a picture of a child over 10. And we extrapolate that then they're going to be fine, but that is in fact really not the case. These are all wonderful results, but none of these are kids that you would see in my lectures on a routine basis. I'm showing you these as a demonstration that we still don't know how Ben here is going to do. And if we also just look at the small cleft, so this child has an anterior cleft and a small posterior palate cleft, skipping the hard palate, once she reaches skeletal maturity, it's a great result. So if we only look at the small clefts, we all do well with them. And it blurs our statistics because we put them all together. It's when we see these kids that we do well now, but we must evaluate them at skeletal maturity. They must have a normal face, normal bite without orthodontia and without compensatory surgeries for speech or for the jaw. So in my practice early on, I was failing in a linear fashion. I was doing well with the small clefts, but it was worse and worse the more complicated they got. And as I looked at them, it just seemed to make sense that there was a major discrepancy in tissue deficiencies going from the top to the bottom. They failed in a linear fashion. So I had to do a critical look at this and say how many of my VO 3s and 4s reached normal face without jaw surgery or compensatory orthodontics and normal speech without secondary speech surgeries. How many of those truly do that? So I looked at 55 patients over 16, non-syndromic, and these are kids early on in my practice and kids that I've seen since from other places as well. And it averages about 50%, or actually more than 50%, need jaw surgery, and more than 50% need speech surgery. Well, how many get away without jaw surgery or speech surgery? 9%. 9%. Well, that means I'm failing 91% of the time. I can't think of any other job where they'd let us fail 91% of the time and pay us. So how about now? Now that I'm using the anatomic cleft restoration philosophy, how successful am I? Well, my first 116 patients that reached 16 years of age, non-syndromic 3s and 4s, only 6.8% needed jaw surgery. needed speech surgery, and 4.5% needed jaw surgery. So now I'm succeeding 89.6% of the time versus 9% of the time. So to me, that was eye-opening and told me I was on the right track. And I continue to refine this moving forward to even get better results. So instead of having these kind of arch shapes, now I have arch shapes that are much natural in their configuration and much healthier looking in the scarring. So now you can get kids that look like this, and they really can do anything in society, and their cephs look normal, and it's repeatable. But you have to keep looking at the overall goal, and I'll emphasize that throughout the talk today. So if we don't achieve our goal, we failed. We have to think about that. So we can't be short-sighted. We must anticipate success, not anticipate failures. We don't want to say, I'm not going to use a buccal flap because I might need it later. You must anticipate your success, not anticipate your failures. So let's talk about complications now. So what's the definition of a complication? Well, medical definition is an unfavorable result either from a health condition or treatment. So it can be caused by our treatment, but it could be due to the health condition. Now let's look at an overall definition. It is a problem or difficulty that makes a situation harder to deal with, or an undesirable development that makes something worse. So we can do something that can make something worse in the future by our complications and by our thought processes that create complications. So let's look at the types of complications we see in clefts and why they happen and what their impact is. Well, it's strictly for palate surgery. We've got wound dehiscence, fistulas, hematomas, infection, really. And I know they happen. I think that the vast majority of your surgical planning issues are going to take care of these things. So we're really going to have only post-op fistulas for the most part. I've never had any dehiscences, hematomas, or infections. I don't know how I got that mark on there, but we did. So why do fistulas occur? Well, number 1, 2, 3, and 4 really is all about reconstructive planning errors. Underestimating tissue deficiency, in my opinion, is the reason that things happen. If you underestimate that, you create tension on the closure. It creates a more difficult wound to close if you don't have extra tissue, so that you have more technical errors. And post-operatively, if you don't have a soft, supple palate, you have a tight drum head, it's going to pop. You're going to get that burst fistula. So once again, as clefts get bigger, more tissue is missing. And so this is where you add the tissue appropriately. Tension on the repair, it's not going to work. That is a scarred area. It is just not going to heal well. This is a better blood supply, much healthier circumstance. You also want to reduce the overall fundamental principle of scar load. And Ahmed gave a beautiful talk last week, and he talked a lot about scar. And I think that's very important. And that's why I say I think all the institutions I've dealt with in Egypt are ahead of the ball game in the world, because they grasp all these concepts, and that's critical. And if you have stuff put in the mouth, and all of us have pulled a lot of things out of our clefts, it's going to happen. We can't avoid it. And fistulas come in all kinds of shapes. And just because you have a small fistula doesn't mean that it's an easier one to close if there's a lot of scar tissue. But clearly, generally, these big ones like this are going to be more difficult. Well, let's talk about difficult. In a very simple sense, your fistulas are either difficult or simple. Or in my opinion, you can call them a nuisance or a nightmare. Well, a nightmare is a terrifying experience, and a nuisance is just an inconvenience. So if I can have a situation where I don't have any nightmares and I just have some nuisances, I can deal with that. If the operation I'm recommending is nothing but nightmares as the complications, that might not be a good choice. This is a nightmare. You can see the scarred tissue here. You can see the damage to the teeth areas. This was predetermined by the operation that was attempted when the child had their first primary repair. Yes, you don't anticipate failure. You do anticipate success, but you have to do that within the means of the present medical available circumstances. So if you only have a limited number of flap options, you want to make sure when you use them, you get the most out of them. And the tissue you have to be respectful of it. So if you damage the gingival tissue and the hard palate mucosa, you cannot replace it very well. So it's very important. This is a tongue flap waiting to happen. So once again, it's a terrifying experience, a nightmare, but it's also a very difficult situation to deal with. And that's the scarred tissue, multiple primary or secondary fistula closure failures, outside flaps often needed, and certainly can have a negative impact on the speech and growth. So buccal flaps themselves are a tool. You can use them for fistulas. They're good for mid-palate and velum. They're not really good for anterior palate, and many will require a splint. This is the arc of rotation. As they get older, the arc of rotation is limited going forward towards the incisive foramen area. This is an example of a buccal flap used in a fistula, sent to me by Cam Patel. He called me up and showed me the picture. I said, here's your options. You could use a buccal flap. It's the absolute maximum range for it, and he did a beautiful job, and it worked for him. Here's one I used for a gentleman in his 60s with a radiated palate cancer. He had a fistula opening. I put in a buccal flap, and it worked nicely for him. But I will tell you, in 35 years, I've never actually used a buccal flap as an added tissue for a fistula in any of my patients. Instead, I'm going to use more likely a FAM flap, a facial artery myomucosal flap that has a artery in the flap all the way to the tip, because the tip is where you have to have it for a fistula. You usually are arcing it instead of insetting it. And so that's an example of the arc of rotation. And this is the example of how it's in its position over the teeth with a splint. And that's the result that you can get later on when it's all healed. Tongue flap, also very good for the most difficult anterior ones. Here's one that I did using a tongue flap. And here's one that my partner, Dr. Polly, did. You can see the scarred tissue here is all the similar circumstance. I mean, these are long operations. These are very difficult to do. And you don't want to have to do this more than once. This is Dr. Aidenwaller from Charles Pinto. He sent me this result, beautiful result. So nuisance is an inconvenience. This is an inconvenience. I put a black dot where there's a small fistula. And before I do the bone graft for this child, I'm going to close that as an outpatient. I'm going to raise the tissue. Now, instead of having relaxing incisions here, I get all this tissue from here up to the teeth. That adds at least a centimeter, 5 millimeters per side of more tissue that I can use to close this area. So when I lift it, I can close that with no tension as an outpatient, and they all seem to work. So the best way to handle complications is not to have them, because when you have a nightmare fistula, you have to go through the process of identifying the fistula, figuring out the tissue replacement, and adding the tissue as necessary. Very similar to what I do at the primary repair. So the best way to handle complications is not to get them and prevent them, whether it's a car seat, inoculations, toothbrushing. Prevention is the key. But you must not compromise the ultimate goal. Don't be short-sighted. And by that I mean, I do know some places where they say, you must not be a very good surgeon because you have a 5% complication rate. I have like a 3% complication rate, but they might have a 1% nightmare rate. I'd rather have a 5% complication rate of nuisances. And I get then more people reaching normal face, normal speech. complications are going to occur. This is a child I did last year, my lip repair, and he took a tumble. And because the lip repair was nice and soft and everything was supple, he's going to be just fine and nothing really burst open. So the complications, let's not get them, but let's have ones that are easy to treat. So my recommendation, you should use the anatomic cleft restoration concept. That's going to give you the most tension-free closure. And once again, I don't believe using buccal flaps to treat the fistulas. I think they're better to prevent them. Here's an example of a wide cleft, the buccal flap in place, and very healthy looking tissue. So looking at my first 29 years, now we've just finished the review of the last 6, so we've got 35 years. And the statistics are going to be roughly the same, so these are going to be adequate here. So 33 total complications, about 1 a year. And not using pre-surgical orthodontia, no relaxing incisions in this group. And the smaller clefts all got the furlough types, larger clefts, buccal flaps were added. All different types of clefts in good distribution, narrow, medium, and wide. Anything over 10 millimeters was considered wide. So what complications did we see? What type of characteristics were associated with the complications, and how did we manage them? So I had no major wound disruptions at all. 2 small mid-palate separations, only 1 actually needed treatment. 1 buccal flap donor site required a minor scar revision for a dental bracket that we were using. So the only other complications were the 30 fistulas, and I categorized them as smaller than 2 millimeters or anything larger than 2 millimeters. I'll show you essentially my largest one. We looked at types of repairs, location, fistula size, syndrome, trauma, width of the cleft, and the Piero band. They were located anterior palate, mid palate, and junction of hard and soft palate, none in the velum. So that's important with regarding scarring for speech. This is the big picture of all the fistulas that I had. More importantly, inclusive of syndrome patients, Piero bands, all comers, 5.5% fistula rate. But looking at fistulas greater than 2 millimeters, only 2.5%, 1% documented trauma. Looking at the non-syndromic patients and non-Piero band patients, it's down to 4.8%, a little higher trauma, but the fistula rate greater than 2 millimeters is only now 1.8%. So most all the fistulas I've had in my career are small. More importantly, they're easy to treat. All fistulas were closed with elevation and rearrangement in a 2-layered fashion. Most are able to be combined as an outpatient with scheduled buccal flap division. And only 1 patient in my entire career, including the last 6 years, required more than 1 operation to close any fistulas. And this was in my 2nd year of practice when I operated a little too quickly. No patients required any external flaps. This is an example of a nuisance. Once again, a lot of them are on the tip, because if you get a full closure like this fairly large VO2, the kids immediately have a new toy. And they'll suck on it, and they'll blow away a little bit of a tip. That's why in my 3s, when I have still an opening in the very front, that small opening from the incisive foramina to the gingiva, the kids can't generate quite that degree of, and they don't damage the tip quite so much. The bilaterals have more problems with the tip because the flatness of the anatomy makes it so that the buccal flap can't reach as far forward. Here's an example of how it's closed again, elevating the entire palate, doing a nice nasal closure, and then bringing it back, and the child can go out as an outpatient. A larger one like this bilateral, I can advance the tissue, advance the buccal flap, and once again, affect a normal closure. This is one of the very worst I had, 2 fistulas, but once again, because the tissue is fairly healthy, you can get a closure in 2 layers. So in summary, looking at the double opposing Z-plasty buccal flap group, the majority of the fistulas are small, less than 2 millimeters. They're all easily repaired as an outpatient, and no patients required external flaps. So we didn't have any nightmare fistulas. These do make me lose sleep, quite frankly. So there's no good answer for nightmare other than prevention is the best option. But it's not over when you get a nightmare fistula for these kids. That's the important thing. It's just goes on and on. Often leads to complex jaw surgeries and speech issues. So I'm going to talk about the tale of two Ks. These are two kids that were adopted at the same time. Caden and Cora. Caden had a dehiscence of his palate, so he's got a nightmare fistula. He's got a very tight lip. Cora came to me with a lip that I could easily revise and give her more of a loose lip, appropriate lip posture. You can see Caden's up there is dehisced, those two flaps, and everything is collapsing. Cora's is a virgin cleft. I can add the tissue necessary. And now she's having her bone grafts. She's got a normal bite. She's going to go on to normal speech. So her sequence is that she's going to have normal speech, normal face. I generally do stage my bilaterals. I do bone grafts one side and the other, and I did 2 splints. So those are separate procedures. So she's going to get a total of 9, which looks like a lot, but that's going to give her the best options for results versus Caden, who ended up, here's Caden up here with this restriction. There's Cora's tissue after the buccal flap release. And he's going to need a superiorly based FAM flap to close that fistula. 3 attempts of me trying to close it, I couldn't get it closed. He ended up, I did get a bone graft on this side to take. I didn't do a bone graft here yet. There's the turnover flap that you use. This is about 2.5, 3 hours of work because it's all scar tissue you're working with. And over here is now his FAM flap healed. It's finally closed, but now he needs a sulcusplasty. So his list of surgeries is 1 lip repair, too tight, palatalplasty dehisced, palatal reclosure, and then 3 fistula attempts, a left bone graft, then a facial artery myomucosal flap, splint removals, sulcusplasty, and then he's going to need 2 jaws to have that done, a rhinoplasty lip revision. So, you know, he's got probably 17 surgeries. Generally, in a small cleft like that, these are Z-plasties, Z-plasties, buccal flaps, always buccal flaps, and as I say, the bilaterals, about 20 to 40% I need to stage depending on the anatomy. So going back and looking at our definition of complicated, an undesirable development that can make some things worse in the future. That's important because if we do surgeries early on that create mid-face retrusion, that actually may make our speech better. It's doing so because the space here is made smaller. And our muscles don't have to work so back in the velum. If they're scarred, if it's retruded, you can get some better speech. But is that a good thing? No, because you're narrowing the airway, which can lead to obstructive sleep apnea and can shorten somebody's life by 20 to 25 years. So while we all agree that pharyngeal flaps and sphincteroplasties are a ticking time bomb because of airway obstruction, so is mid-face retrusion. So when we look at this historical patient and we see this mid-face retrusion, we need to recognize that this is a today's patient. This is a patient with this cephalometrics that presented not too many years ago to my partner, Dr. Polly, when he was in practice in Chicago. And this was the inspiration for him to develop the RED device and began realistic facial distraction in these very severe retruded faces. So here's an example of that. Here's a patient of Dr. Polly's, and you can see the bite and the mid-face issues, and there she is in her RED device, and she is going to be moved forward 30 millimeters. So now you can see this retropharyngeal area. So now she has been corrected beautifully. There's her lovely bite. There's her lovely face. Now we fixed her face. and her airway, but now she's lost speech. So this is a very important point when we talk about complications and things we need to learn, because if we have mid-face retrusion and we say we have 80% normal speech or 85% normal speech at 7, but when they get to adolescence, then you've got a 50 to 60% chance you're going to need jaw surgery, and of those, 20% are going to lose their speech. What is your true speech result? Brian Summerlad, when I talked to him, told me, he said, even without jaw surgery, I lose 12% of my competence at adolescence, 12%. My result of that is 1%. So here she is getting her palatal lengthening. And fortunately, it worked for her. So a year later, she's back to normal. But that's another major operation with, not 100% success rate. So what other complications? Well, we talked last week again about scar load, and I had some comments about lateral relaxing incisions. So this is Dr. Colasta from Stanford, and he called me up and sent me this picture. He was just learning Z-plasties. He did his Z-plasty, and he ended up with that. So I don't think I can get that closed. So, well, you can do the relaxing incisions, but you've already made your cuts way back here, so that's going to be very hard. So he decided to use buccal flaps, and he got it closed, and that kind of started him on the direction. So in his more severe clefts now in Stanford, they use buccal flaps to fill in tissue. But buccal flaps, as we say, it's not a magic wand. It's not the answer. Dr. Ian Jackson, who many of us know, and he was a great friend to me. I mentored with him all the way through my residency, because I was born at the Mayo Clinic. When he was there, I would go back and visit my family, and I would watch him do surgery. I had my own mentor for many years, and when he moved to Michigan, I would stay with him and watch him do surgery. And I did a series of Jackson repairs, and this is an operation that I did, and you can see a lovely result as a child, but you can see that just the relaxing incisions is the only difference, and the scarring that you can get, and ultimately jaw surgery. So it's what you do with the buccal flaps, and including the whole process of the anatomic palate restoration philosophy. So here's a wide bilateral, the buccal flaps and Z-plasties. There it is, healed. And you can see her facial posture is much more normal at this age and will be repeatable, and I'll show you results later for her. So what is the full recipe for success here? Well, if you're baking a cake and you leave out chocolate, you're going to get a cake, but you're not going to get a chocolate cake. So you don't get all of it. So really you have to do everything. And this is an example. This is another bilateral cleft child, and you can see even without a rhinoplasty on this child, if you stage the lip, I can get some columellar lengthening early on that allows the tip to come up more naturally. He's had just very basic orthodontia to do his bone grafting, but he has not had any work on it other than that. So he's had his lips, his palate, he hasn't even had a rhinoplasty yet. So I'm seeing the rate of palatal fistula. All right, so it's not 0, it's not 10%.
That's a quick poll just to check everyone's idea.
So I'm just going
to just move it to the side and everyone.
Oh, move it to the side. Okay.
Yeah, that's okay.
Oh, I can just do this. So what's the recipe to achieve normal face, normal speech? Well, I'm going to talk about normal speech first. And that is, if you follow the anatomic palate restoration concept, you'll improve your speech results. That's the step 1. Okay, now it's not moving forward for me for some reason. So once again, in my paper that I presented in 2011, 93.4% normal resonance, regardless of the cleft or classification. So instead of having a linear failure, they're all the same. So now I'm up to this result across the board. So that's what you need to do, or at least that's what I do. The facial reconstruction, getting a normal face, is more problematic. There's more things that have to be done. These are the last 5 things. Early bone grafting and periosteoplasty, there's an impact. Retromolar periosteal dissection is an impact. Tight lips, and the wrong use of orthodontics. So let's talk about those. Gingivoplasty and early bone grafting reduce the overall arch. Here's a child, I did a double buccal flap, double Z-plasty, but I did early periosteoplasties. I'm just like everybody else. When they came out and said these don't impact on facial growth, I said, okay, well, I'll do that because it'll save me a step later on. Makes sense. The problem is it doesn't work. Here's a child, and here's his result. Looks the same as traditional repairs. He had normal speech, but I don't know whether that's because he's retruded or not. Periosteal shifting of any kind makes bone. We know that ever since Torg Skood published it years ago. That's a massive metabolic response. So we looked at 92 patients with early periosteoplasties and no periosteoplasties, and it was statistically significant, more complicated orthodontics required and more orthognathic surgery required if you did periosteoplasties and early bone grafts. So it affects and restricts the arch shape. We've been told this since the early 80s by Berkowitz. But Dr. Berkowitz, if you ever see him at the ACPA meetings, always stands up and tells us this, and he's 100% correct. The problem is his answer to the solution, this problem, his solution was, don't close the palate. But the problem with that, of course, we all know that has negative effects on speech. So he hasn't really changed that. I think that by adding tissue, we can improve the speech and still get the growth that you want. Here's an early bone graft patient I did. You can see exactly the same as everybody else's. So retromolar subperiosteal dissection. So in the retromolar area around, you can either slide in that natural plane or you can stay preperiosteal. I think it's very important for maxillary retrusion, and that's demonstrated in Enlow's book, Facial Growth. This is what I would say, this gentleman over here doesn't need jaw surgery. She has a bite that is just a little off. She's got good facial profile, but she is still considered a failure in our statistics. So when we looked at the VO2s, our need for jaw surgery is very low. It's actually low in the VO3s and 4s too. But when I have visited other countries that do subperiosteal dissections in the retromolar area, they have a significant number of kids that have the mid-face protrusion. So I think it is a reality that it does impact it. Relaxing incisions, we talked about that. It causes lateral constriction. And this is what we've all done them. And I will do them in the VO2s occasionally. And this is an excellent result of a traditional repair. But you can see even with this, there's a constriction laterally. They don't get the wide arches. And here's another example of that. They're a little narrower. So it is just one more thing that adds to it. And certainly you can get shifts of the teeth due to the relaxing incisions, that you get this kind of bending look where the teeth get out of position caused by the relaxing incisions. And these secondary scarrings instead of these arch shapes, which are much wider. Tight lips, also very important, and create, even with a good arch shape, poor facial posture. The Functional Matrix Theory is, I think, an excellent book for everyone to read by Melvin Moss. It all talks about the impact of soft tissue to the face. That's why we see unrepaired clefts, the facial posture overall is good, instead of this, which we know is going to have detriment. So here's an example of two children adopted with two different types of lip repairs. A tight one, so her lip posture is this, but even with her arch shape and bite normal, she still has poor soft tissue posture. And it gets worse and worse versus her sister who had a minor cleft, so it was a lot softer repair and gets much better by maxillary projection of the soft tissue. So do not remove tissue from an area of tissue deficiency. This is just doesn't make sense to me with any fundamental principle of an area of tissue deficiency to take more from that area. Instead, you're going to want to stage it like this so you can get a lip that has nice projection so that she can look much more like her twin sister and not have a retruded face. Or here's another complete bilateral. You can stage it. You can get a very soft lip going forward. Pre-surgical orthodontia as a wonderful tool. whether it's done in static or active. I think it's very important for a collapsed cleft. These should be expanded out so you know how much tissue to add. Otherwise, they're going to be restricted and you're going to have a mid-face protrusion guaranteed. Most clefts are expanded so you can bring them to a normal shape, but you don't want to bring it inward more than this because you won't be able to identify how much tissue you need to replace. All these impact orthodontic care. My good friend Pedro San Diego at Duke, who many of you know, as I've gone to his workshop, and he tells me 100% of his patients are in anterior traction face masks like this little girl down here. And I looked at that and I said, well, I don't think our patients enjoy those, so how many of ours need them? And they only need them about 16% of the time versus 100%. So is it repeatable? Well, let's look at some patients that are had just a cleft lip, palate bone grafts, and rhinoplasties. Here's this gentleman again, and this is important. You can see his bite, and you can see his normal ceph. So we're looking at all the cephs now. Here's a bilateral. You can see his bite. Here he is after his rhinoplasty. Here he is with his ceph and his new young bride. Another bilateral. Here's his ceph. And we're analyzing all these, and we'll be writing this up hopefully within a year or two. We'll have that all out for you, hopefully a year. So they're very repeatable. All 3s and 4s. So once again, we know the malformation is missing tissue. So with that, if you have a malformation, if you don't replace the tissue, you don't have the result. Now, sometimes you can't replace it. We can't put a thumb in. But if we don't have the exact right tissue, replace it with something that's as similar as possible. And that's where the buccal flap has added a lot and improved a lot of areas in my practice. It's improved my lip repairs because my lips are a lot softer now. My palate's a lot more consistent. My VPD management is better. My fistula management is better. And it's consistent regardless of cleft width or complexity. So I think it's very important to use the team concept. You've got the opportunities with all the orthodontics and speech people. I think that's critical. I think keeping an open mind, remembering to not be short-sighted, and remember that all clefts are different, because change is coming. And I think we used to think the world was flat, and it's now, we know it's around. I'd like to thank you very much and look forward to taking any questions going forward now.
Dr. Robertman, I really appreciate your talk. Such an insightful talk, and getting a lot of experience over the years, of course, because such a topic is really challenging. Thank you again. And now maybe Dr. Khaled first, our head of the department, give us a word, and then to the discussion. Dr. Khaled, are you with us?
Yes. Good evening, everyone. Thanks, Dr. Robertman, about this extremely difficult topic about the palatal fistula, and I think this is one of the best topics you can be challenging for any plastic, pediatric, or any surgeon who will attempt for closure of this fistula. And thanks again. And I welcome all our colleagues all over our universities in Egypt. And thanks, Dr. Dawlat, Dr. Ahmed, Dr. Haitham, about these arrangements. And I open the discussion, and I hope we have a fruitful discussion. Thank you all. Thank you, Dr.
Thank you, Dr. Khaled. Dr. Dawlat, I think you have a question.
Yes, Dr. Robert, I just see in one of your slides that you make a stage repair for the palate, for some kind of palate. So I want to ask, what is this stage repair?
So in the VO1s, 1 repair. VO2s, 1 repair. VO3s, 90% of the time, 1 repair. Once in a while, the anatomy will make it such that the buccal flap won't reach quite far enough to the anterior palate, but it's less than 10%. The bilaterals, that's a limitation. We only have, in a double Z-plasty and a buccal flaps, 6 flaps to work with. A Brunner flap, an anterior non-vascularized arterial labial flap, a Brunner flap is just mucosa, can be used to close the anterior palate, but it is not highly predictable. And so I frequently on a pallet will only put the buccal flap as far forward as I need to go, as I can go, excuse me. And I will tell the family I'm going to come back and I'll close the anterior pallet sometime in the future. It's amazing how many times the wide vomer is right next to the collapsed lateral shelves, and the kid's speech is normal. And then when you are going to do your bone grafts, I just do like I close the fistulas. I raise all the normal tissue because once again, all your tissue has not been violated, and you can do a nice anterior closure as an outpatient, and then I do my bone grafts. So I would say 20 to 40%. I don't exactly have the number. It's not going to be higher than 40%. It's going to be closer to 20%, I think, that I've staged over my career.
Okay, thank you.
Thank you, Dr. Robert. So there's a question from Kedum Shaba, and I also have the same question. I was wondering, so do you use interposition layer in terms of biological or synthetic between the nasal and oral mucosa? In case of prevention, as you explained, you always think prevention is the best way to go. So would you use an interposition layer like a buccal pad of fat, or maybe even a cartilage or an ADM even, to reduce fistula rate?
Once again, I think from a philosophical standpoint, if I'm looking at the anatomic cleft restoration philosophy, it's try to reconstruct it in a normal fashion. And so if you're working that way, you want to use autogenous materials, and as a last resort, you'd use an interposition of something like, one of your dermal substitutes. They've had varying success, mostly not great. I know Joe Losi was a big advocate. He's no longer doing it at all. He's gone instead to using the buccal flaps. I think also with the fat has a place for me, once again, in one of these nightmare fistulas that I can get the fat too. I don't like to use the fat at the same time I use a buccal flap because the scarring that you can get around the base of the buccal flap can compromise its vascularity. My friend Frank Pepe at Cleveland Clinic does do the fat and the buccal flap at the same time, and he has told me he's been doing well, but I haven't seen his long-term results yet. Does that answer your question?
Yes, thanks. It does answer it. So one of our attendees was wondering, you explained that last time you were with us in the meeting, how you place your buccal flap. So he was asking if you reposition the muscles in the posterior position anatomically, then with the mucosal defect or that you need to restore, you place the buccal flap.
Yes, I mean, once again, if you're going to think about reconstructing it anatomically, Braithwaite to Summerlad has told us we must get the muscles in a better position. Whether you use a Z-plasty to do that or a combination of a Z-plasty and some sort of interpositional intervellar vellarplasty like Albert Wu does, the important thing is to get that in position. The missing tissue is the tensor veli palatini aponeurosis and the mucosal deficiency of the velum. That is first and foremost that needs to be reconstructed so you have a normal anatomic speech engine. That speech engine is the thing I'm reconstructing in the bilaterals at the expense of the anterior palate. I'm going to use those 6 flaps first and foremost for speech, and I will stage the anterior palate to get closure later. That's why I do it that way, because I never want to take a big wide Piero band Vo 2 and get the palate, hard palate closed at the expense of velar function and length.
And shortening, yes. Yes, I understand, thank you. Dr. Mamdouh, I unmuted you, you have a question, sir? Dr. Mamdouh Abul Hassan. Okay.
I have a question. Is Mamdouh Hassan somewhere out there?
Yes, he's with
Yeah.
us. I thought he had a question.
I would like to ask him a question because as he will know. He came to visit me and spent a week with me, and I think we talked probably for about 10 hours a day on the management of clefts. And when we weren't falling asleep from jet lag, I was returning from Australia and he was coming from Egypt. But we had a wonderful time. And I think he saw that my kids do speak normally. And that's been the thing that most people, when they have come to visit me, have said. And he is, I know, embracing it. I would like to ask him, what was his fears about making a change? And now that he's been doing it, what does he see as the biggest advantage? Those are my two questions for him.
Yes. Do you hear us, Dr. Mamdouh? Okay, maybe we will get him back. Do you hear us? Dr. Mamdouh, are you with us?
Yes, I can hear you well.
Yes.
Hello.
Did
Hello?
you hear my
now?
Did
Yes,
you hear
we
my
can hear you.
question, Mamda? Mamda, did you hear my question?
I think maybe he has internet problems.
Okay,
Okay, so maybe I could shift to the poll questions quickly. So
sure.
and take your opinion
Yeah.
on that. So
Can you
my
hear me?
yes,
Yeah,
we can
Dr.
hear
Mamdouh,
you,
I can hear
Mamdouh.
you.
Okay. So maybe we'll get back to that. So the poll question we started, what's the fistula rate in practice? As you explained to me before we started, they don't consider all fistula the same. Of course, the size of the fistula, the size of the fistula are all factors to consider.
Yes, I think it's a big mistake when I hear some people say, "Oh, you know, my goal is to have no fistulas." Well, of course, that's everybody's goal. But if you use that as your goal and you miss the overheading goal of having normal face, normal speech, then I think you're not doing it correctly. Because I've been at meetings before where people have said, "Wow, your fistula rate's way much larger than mine. I only have a 3% fistula rate, and yours is 4.8%. My surgeries clearly must be better." I think that's a bad measure. I think the measure has to be looking at the overall, and then are the fistulas something that you can easily handle? Because
So
if you had a
you always
3%
use,
fistula rate and a 1% nightmare fistula rate, I certainly wouldn't want that.
and you usually go for the functionality and the lengthening of the velum. Even if there is some tension, you usually go for a buccal flap to restore or replace this deficiency. But others maybe go for a tensionless closure, but maybe a shortened velum. So that's your philosophy, right?
Correct. Yeah, because I think then they're being short-sighted, and then the kids 5 years later. So I know of an institution, I won't say the name. Their goal is to have no fistulas, and 5 years later they will, do pharyngeal flaps and sphincterplasties with fair regularity.
Yes.
Yes.
Dr. Mamdouh, I think
Ahmad,
we
can
have
you hear me?
yes,
Can you
please
hear
go
me?
ahead.
Yeah. Okay. Okay. Thank you, Bob, for the nice presentation. And for those who doesn't know, Dr. Mann, he's a very good host actually at his place. So I encourage everybody to visit him in Michigan and spend some time with him. You will benefit a lot from him. Actually, it took me more than 15 years to change my philosophy. Actually, after I've seen his presentation about 8 or 10 years ago in the ACPA meeting, and he had a nice course of explaining his philosophy. At that time, there were no much surgeons using the buccal flap as a primary thing to use in the primary repair. But what I had a problem is I've seen my patients at the age of 16 and 17, and Bob showed part of his results early of this constricted arch and the need for the maxillo facial surgery in older ages, and his percentage has diminished from 89%, I think, till 10 or 9%. So this is a major improvement actually. And the example he gave by the two patients that each one had 8 or 9 surgery and the other had to go through 17 surgery. This is a burden of treatment that we are, as a physician, doesn't take much into consideration. But when you look at from the patient side, if you have to spend 4 or 5 years of your 15 years age, yeah, just nearly 30% of your time in
Are still with us or connection problem?
Well, I'll make a comment on that if that's okay.
Yes.
Number one, I wish I could have everybody come and visit me and watch me do surgery in Grand Rapids, but I'm actually retiring my clinical practice in the next year. I'm doing only a very few surgeries coming up, so it is not as easy to come and visit and watch me do a series of clefts.
Yeah, we're gonna come
However,
anyway.
I will. You're welcome to come anyway. I would love to have you and show you
Thank you
around,
so much.
and you can come and watch my partners. But I will put a plug in for the meeting in Cairo, hopefully next January, February coming up, where I hope to be doing surgery in Cairo. So anybody who can watch the surgeries being done there. And the surgeries, I mean, you're all great surgeons. You're going to know how to do these things. The key is to have enough data that I can show you that you can recognize that it's worth doing now, because you're going to have to wait 16 years to see if you're right. So that's why I'm trying very hard to give you all the studies going forward, so you can see that, yes, the midface protrusion is not foregone conclusion. Yes, these kids do speak and look normal, and they can have the life that we all want for all our children.
Yes, so to remind the Mufti on the same topic, the same subject, he placed a comment. So is mid-facial retrusion an intrinsic factor in cleft palate, or is it an iatrogenic result of palatal surgery, or a combination of both?
Well, and there's studies out there. I mean, if you look at a study from Northern Europe and England, it's about 7% of that population will be benefited from jaw surgery without syndromes. So what is the overall population? I think Asian faces tend to be a little more retruded, even if their occlusion is normal, with the most projection being in Africa. But with the cleft children, it's probably slightly higher than whatever their general population should be. And the rest of it is probably caused iatrogenically by us. And I think that's really what I've shown. After 35 years, is the result going to be 4.5% need for jaw surgery, or is it going to be slightly higher? But it's not going to be 50%, I'll tell you that.
Yes, you believe that the releasing incisions in the dissection usually cause such a defect?
It's the combination. That's why I say, if I look at my kids that I did a tight lip repair early in my practice, those kids have more crossbite issues than my kids that I staged the lip. The kids that had relaxing incisions have more constriction than when I gave up relaxing incisions. When I stopped doing retromolar subperiosteal dissection, everything adds up. So figuring that these kids probably have a slight increased risk over the general population, let's lower all their risk factors. That gets them closer to normal.
Yes, helps them get there. A question to Atif was asking, do you ever use a tongue flap? I know you place it as an option, but in your practice, did you ever use it? And in such a case, I'm sorry, this next question, the same thing. Do you usually use an anteriorly based or posteriorly based?
I've never used a posteriorly based. I've only used anteriorly based tongue flaps, and I try to do them as limited as possible. And I won't do them in children because it requires a lot of compliance.
Commitment. Yeah.
I will do a FAM flap anteriorly based to close those anterior fistulas in a slightly younger person. I showed you an example of a tongue flap I did and
Yes.
a anteriorly based FAM flap, but they're brutal operations. I mean, a FAM flap takes me 2.5 hours to dissect.
Very meticulous.
And if you lose it, it's you just can't lose it. I mean, I've been very lucky. I've not lost one, but I haven't done 100. I've probably done 20 of tongue flaps and FAM flaps together.
Thank you. Dr. Helmi Shalabi, you'd like to ask a question yourself?
Thank you, Dr. Mann, and thank Asr Al-Aini staff. I thank you very much for this very good and lecture that tackle a very hard problem. I'd like to add to your the dissection, especially subperiosteal dissection of the hard palate, or the medial pterygoid plates, or the so on, add to the retrusion, to the effect of the surgery on the growth of the maxilla. And in technique that have very much dissection of the subperiosteum, or the surgeon that is rough in his dissection of the subperiosteum will sure affect the growth of the maxilla. And also, I'd like to add that a circumferential scar of the releasing incision, lateral releasing incision, or a circumferential, even external in repair of the lip, external incision around the alveolus would restrict the growth of the maxilla. I'd like to ask about the mega fistula, or that you called a nightmare fistula, mega fistula. Does it has effect on the speech or not? Thank you very much.
Well, thank you very much, Helmy. I totally agree with you. The elevation of the periosteum is important, but the more important factor is what you do with that periosteum. So if you have a fairly narrow cleft and you elevate it and you have a relaxing incision and it really didn't shift at all, it's the shifting of the periosteum that creates the separation of the periosteum from the bone that creates the metabolic effect. So it's like if you have wrestler's ear or boxer's ear, where the cartilage the perichondrium gets separated from the cartilage, it tries to create cartilage and that creates that deforming area. It's the separation. So that's why if you just elevate the flap, so when I elevate the periosteum, but I'm putting it back right where it was, so it doesn't have an impact. It's the separation. And I think when you do this, like you say, circumferential scarring is always bad. With regard to your description of the nightmare or mega fistula is another very good way to describe them. But once again, sometimes a very small fistulas in a scarred area can be just as much of a nightmare. Well, I think all of those can have impact on not just the facial growth, but a lot of times the surgeons are trying to close the fistulas by sacrificing the soft palate tissue. In other words, they move things forward as much as they can. So I think the overall scarring is an issue. I think your comment on the roughness of the surgeon, I think we all can strive to be better surgeons, and we all should strive to be better surgeons, and we all should strive to get the best education possible. But I do think that we all have the capability to be that surgeon and do the great work. I don't think anybody out there can do what I've described. And I have people now all over the world that are doing it. And some people are doing it just literally by looking at my videos. I was at a meeting in Utrecht not too long ago. I saw a lot of you there. And I had three gentlemen from Spain come to me, and they said, we love your stuff. We've totally changed our philosophy. We're using your philosophy all the way through. And I said, have I met you yet? And they said, no. Well, how did you change? And they said, well, you met our fellow a year ago in New York, and they got on my website and could see, or my Google Drive, and they were looking at my videos without any narration, and they were starting to do the surgery. So you can get great results, but you just need a little bit of training to get it there. Helmy, did I answer your question appropriately?
Thank you very much.
Thank you, sir.
But I was commenting on as some people in the Scandinavian area trying to close the soft palate early and leaving the hard palate for a long time. I think the fistula, I call it fistula, mega fistula, in the hard palate that may be left to the 7 years or so on. This mega fistula may affect the speech. Sure, will affect the speech.
Yes, very much so. So when I came back to Grand Rapids after my training, the people in Grand Rapids were doing the stage Schweckendeck approach. So you do a closure of the soft palate, and you would stage the hard palate with appliance for a number of years. The problem with that is that there's a band behind where the tensor veli palatini aponeurosis should be that just turns into a block of scar, and that's what you're referring to. So even though the anterior palate was still unscarred and you could get that closed, it impacted negatively on speech. So that was the major consequence of it. And also, if the Sweckendek data was such that they were closing it at age 2 with large relaxing incisions in the larger clefts, and they still had the same midface issue. So now you've got bad speech and bad midface. So it really wasn't a very good repair.
Thank you.
Thank you, Dr. Robert. Dr. Mamdouh, I placed a question to Mamdouh Al-Hassan. He was wondering, do you overlap the muscles during your repair, or do you suture them side by side?
The overlap of the furlough is less than it kind of shows up on the pictures most of the time. There might be a little bit of an overlap in the anterior part, but not so much at the level of the uvula, if you will. So I don't. If I dissect my levator out like I do, I can see where it needs to go end to end, and if that's kind of where it goes, I'm okay with that. I have a question for you, and this is why I say there's limitations, because I'm only able to work in the context of the generation that God gifted me to be here. So one of my questions is, how tight are those muscles truly supposed to be? Nobody really knows that.
Yes.
I do know that if they're looser, that scar tissue is going to add some in the process of healing. So I try to get a relatively limited tightness to my muscles. I don't want any sclerosis in the muscles themselves. So I'm not going to overlap them. If I can get them together with soft, good closure, that's more important to me. I can always tighten them, but I can't make them looser.
Yes. Thank you. So another question, Dr. Abul Hassan. Have you ever used PRF as augmenting your repair, for augmenting your repair? PRF.
Bone morphogenic protein?
Yes.
I did a few cases with an oral surgeon that liked to do that. I think the important thing in the bone grafting, and is that what they're referring to, is in a bone graft area?
Yes.
Or are they thinking about it in any other way?
Yes, I think this is the way
bone
it should
graft.
be used. Yes.
Okay. So I think it's in the United States, it's not FDA approved for children. It's only under specific guidelines. One would be failed bone grafts. I think you should not have a failed bone graft if you don't damage that tissue early on to try to get a repair. Once again, now you're being short-sighted. I did a study of 99 consecutive bone grafts, and I had one failure that came to me from another place where there was scarring, and I didn't even recognize it. So she sloughed part of the covering, and of course the bone graft failed. But other than that, all bone grafts should work. But if you scar that tissue in your primary repair, yes, you probably are going to have a higher problem with bone grafts, and you're going to seek out other ways. But right now, that's very expensive, and I've never had a complication from a donor site in 35 years, 0. So I don't think that's a big issue. I think you just have to, fix it, make sure you don't scar that tissue, and then you can have a good bone graft.
What do you consider regarding platelet-rich plasma, like a PRP placement at time of repair?
I have no experience with that. I don't have any problem with that. That's that once again from an anatomic standpoint, that makes sense to me. I think it would be a reasonable thing to use. Once that becomes cost effective, I think that would be fine.
Yes,
I have no experience.
Was referring to that. I might have misread it. So you don't have much experience with that. You don't think you usually need it?
No, I haven't used it, but I've used similar things in craniofacial surgery. And in craniofacial surgery, I've had some experience there, and that's been successful. I just have not used it in the palate per se. But I would have no problem, and I would love to see some articles on that if that would give us a little extra boost. 3
I think
more
Dr. Hassan himself is practicing that and using it. He's with us now. If you'd like to comment, Dr. Hassan.
Yes, I meant to using the PRF during the palatal fistula repair as a third
As
layer,
adjunctive.
as adjunctive layer to help closure of the fistulas, actually, especially in the hard palate area.
I think
Yeah, I
Dr.
have no-
Hassan, you have
no
experience
problem.
with that, right, Dr. Hassan?
Yeah, we did a study about 2 or 3 years ago, and it was, I think it was an adjuvant and very effective, and limited the number of the recurrent fistula after that. So I think it's something natural. You get it from the patient, just a 10 cc of the blood, and just have a centrifuge and get it in less than 10 minutes, and just put the plug as a second, as a third layer, actually, in between the oral and nasal layer.
Thank you, sir. We have another question regarding the tongue flap. Everyone wants to know about the tongue flap. So do you use MMF or any sort of mobility reducing method when you use a tongue flap?
Yes, I treat him like an Abbé flap, and I put him with some IV loops. I don't do a full
MMF.
arch bar,
Yeah.
but I'll do some IV loops so that they can move their teeth a little bit, but they can't really open their mouth at all. And I do that for 2 weeks, and then I divide it 2 weeks later. I do the same with my Abbé flaps.
Yes. Well,
I'm a chicken. I don't like complications to begin with, and I definitely
you'd
don't want
rather not,
secondary.
yes, of course, makes sense.
So I'll make one comment. Patients will let you do as many operations as are successful. Once you have a failure, your patients lose confidence. If I tell people we're going to do a staged operation, I'm going to do the nose first in your baby, and I'm going to do the lip, nobody is having a problem with that because they look at the nose and they say the nose looks better. And then I do the lip. So I make the cleft lip into a nice incomplete cleft, and they see an improvement, and that's the goal. And then we fix the next and they see the goal. And now the patient says, oh, Dr. Mann did 2 of them. They've done great. Then I do the palate, and that goes great. And then the kid speaks, and that goes great. So they'll continue. And then I do the bone graft, and that goes great. And then I say, well, I'm going to bilateral. I'm going to do a stage, what I call a step rhinoplasty to give you a longer columella if you need it. So I do that, and they have no problem with that as an outpatient. Then I do some fat injections to make their lip. They'll continue to let me do surgeries as much as they need to get to that endpoint. But if you fail, if that bone graft fails, they're going to go, I'm not so sure I want to do another one. And they'll live without it. And that's a tragedy. So you have to really, but if it's a little nuisance and I close that fistula that I get when I'm dividing the buccal flap and doing that second stage lip repair, or I'm doing it at the same time or just before my bone graft, they don't have any problem with that.
As long as it works, they wouldn't mind.
They don't mind.
Yeah. I think I have the last question. To Yusra Yassin, are you with us?
Bless you.
Okay, so if you don't mind, I'd like to end up with our pause, the second poll. So I'd like your opinion on that. When do you go for a fistula repair? For how long would you wait in your case, in your patient?
It totally depends. It has to do with the timing of what you're going to do next. So I'm not going to do a fistula repair most of the time until they have all their teeth in, so that I can get so I don't have to use a relaxing incision. If you don't have the teeth in that alveolus, and you can't do an interdental closure. So you need the teeth there to time out the closure in the anterior palate. If you have a fistula in the mid palate, or the fistula is in the soft palate, those I think you want to wait 2 years before you do it. It's got to be soft and supple, and then you go back and you can close that. But the hard palate, I wait until they have all their teeth, and then I wait until I have a very compliant patient so I can do them as an outpatient. Patience, patience, patience.
So you consider waiting till the teeth come out, and then you go for the relaxing incisions to fix the anterior fistula.
Interdental incisions versus the standard relaxing incision. A standard relaxing incision doesn't give you as much as an interdental incision. Gives you another centimeter to work with. It's just a much better way to close it.
Okay, great. A question I think you've answered. You have a lot of options, but you usually appreciate a buccinator flap as a prevention rather than a salvage. But what's your workhorse? I have to ask that. What's your workhorse for repair? A buccinator, flap, FAM, or tongue, or any other for fistula management?
Well, anterior fistula, it's going to be a buccinator. Excuse me, it's going to be a FAM or a tongue flap. And for the most part, the mid-palate fistulas I can use a buccal flap, but I've never have had to. And so that's how I would do it. Mostly a FAM or a tongue flap by the time I see them, because there's so much scar tissue around them that the flap is always much bigger than you think it's going to be.
Yes, yes. Dr. Robertman, Associate Clinical Professor in Surgery and Pediatrics of Michigan State University, Oral Cleft Program Director at Helen Davis Children's Hospital, Grand Rapids, Michigan. I really appreciate having you with us tonight and give us the time. Such an illustrative presentation and talk and an insightful discussion. Thank you again, and really happy to having you tonight.
Well, it's a pleasure. As I say, please share my email with anybody to get on my Google Drive to see the videos. If anybody wants to have an individual, I mean, I am available virtually. So if any one surgeon wants to go through the videos with me individually, we can set up a time and I'll be happy to do that. So we'll walk you through how to do the surgeries virtually, anytime, any place. That's the lovely thing about this. So please take advantage of that.
I really appreciate you. You're such a great professor. I will be sharing your contacts in my next announcement, if you don't mind, as you just told us. Also, I'll be sharing this video of our meeting tonight on YouTube. And hopefully everyone who've missed it tonight will be able to see it later on. Thank you again, and see you very soon. Thank you, Dr. Robert.
Thank you very much. Goodbye, everybody.
Thank you. Thank you.
Good night. Thank you.
Thank
Good
you,
night.
Dr. Mann.
Thanks, Mamda.